All right, we are going to go ahead and get started. I apologize, we started a few minutes late. We were just wrapping up the poster presentation. There's lots of seats, so we can squeeze in. We were much tighter at the keynote address. So welcome to the oral presentations. So you're going to see presentations from our faculty, from some of our community physicians, and then nursing and resident staff as well. So these are really the kind of the top projects that were picked out by the Research Day Committee, and there were actually a lot of submissions this year for oral presentations, and we only have room for 6 in this type of day because we go back to back and try to fit in lots of good stuff. So I would just like to recognize our judges one more time. If our judges could stand up in case people weren't here earlier. We have some really stellar judges that have come from all over, so I did that earlier too. So I just want to thank you so much for your time today, and I gave them chocolates, so hopefully that'll at least get you home. All right, so we're going to go right from presentation to presentation. Just a reminder to the oral presenters, you have 15 minutes only. So I would keep your talk to about 10 minutes, and then 5 minutes for question, and then I'm going to cut you off. So it's not you, it's me. We're just trying to stay on time. So Dr. Joseph Feuerstein is our first speaker here. I'll get out of the way.
Hi, I'm Dr. Feuerstein. I'm going to pass this over to my 2 research assistants. I'm the Director of Integrated Medicine at the hospital, and this is a 5-year study that we've done. It's actually a preliminary study. We have another 100 patients to go, and then we will be presenting that next year at an International Integrated Medicine Conference and publishing it. But just want to tell you, we have Krista, who will be a doctor at some point soon. She graduated from UConn, and she is graduated in French and political science. Very nice. And now she's done a post-bac and is going to go to med school. And this is my beautiful daughter, who is also my research assistant, who is a second-year student at the Jewish High School of Connecticut. And with that, I'm going to pass it along to these 2. Okay.
Thank you for the introduction. Good morning. Or good afternoon. It's still morning. Good morning. So we worked with Dr. Feuerstein on this research project, essentially to analyze a natural method of lowering cholesterol. Elevated low-density lipoprotein cholesterol is a significant risk factor for cardiovascular disease in the United States. Here it's estimated that 42% of females and about 34% of males have elevated total cholesterol. Current therapy for lowering cholesterol primarily utilizes reductase inhibitors, in other words, statin medications. However, due to the adverse side effects patients experience, many of them seek alternative therapies in reducing their cholesterol, managing their hypercholesterolemia. Red yeast rice has been used as a food and as an herbal supplement in China for centuries, in addition to phytosterols, which are foods similar in structure and function to animal cholesterol. And in clinical studies, both of these products have been shown to significantly reduce LDL cholesterol.
An 18-person case undertaken by the principal investigator, Joseph Feuerstein, in April 2012 was published in the Journal of Dietary Supplements. This series used a proprietary blend of 1,200 milligrams of citron-free red yeast rice and 1,250 of phytosterol complex. Data shown a statistically significant reduction in total cholesterol, 19%, 46 milligram deciliters, and LDL cholesterol, 33%, 53 milligram deciliters. After 6 weeks of use without any reports of muscle pain, abnormal liver tests, or any other side effects. After permission from the IRB, we performed a retrospective chart review of all patients at the Center for Integrative Medicine and Wellness who had been prescribed natural low cholesterol, which was taken before breakfast and dinner at 5 grams serving scoop of powder added to 2/3 ounces of almond unflavored soy or 1% fat milk by the principal investigator, Joseph Feuerstein, between February 2011 and December 2016 in an effort to further investigate the clinical effectiveness of this natural product in lowering total and LDL cholesterol. After data de-identification, an Excel spreadsheet containing all data was emailed to the statistician for statistical analysis using the SPSS program.
So in the current study that we're presenting, 50 patients at the center were prescribed Natural, among others, but as Dr. Feuerstein mentioned, this is just a preliminary study. 50 patients were prescribed this during the 5-year period. 17 of the 50 were lost due to follow-up. Of the remaining 33, 6 were male and 27 were female, with a mean age of about 62 years. The average baseline total and LDL cholesterols were 243 milligrams per deciliter and 160 milligrams per deciliter, respectively. Average baseline total and LDL cholesterol after lab testing after 6 to 8 weeks on the supplement went to 183 milligrams per deciliter of total cholesterol, which is down 24% from baseline, and an average LDL cholesterol decrease of 33%, going down to 105 milligrams per deciliter. No abnormal liver function tests, muscle pains, or other side effects were reported while using the Natural product. Standard deviations are 42.8 and 31.9 for pre-post total cholesterol measurements, and 36.8 and 26.2 for pre-post LDL cholesterol measurements.
So in conclusion, this 5-year retrospective chart review reinforces the clinical effectiveness of natural low cholesterol and is significantly reducing both total and LDL cholesterol in patients with hyperlipidemia. Thank you.
Questions, anybody? I'm going to answer the questions, I think, or not, or I'll just sing a song. What you got?
I'm not sure if I missed it. Were the patients on any statins?
Absolutely not. So I have no problem with statin medications. If you've had a heart attack, if you have diabetes, go on a statin. There's no question. Statins are great. They have plaque stabilization properties. They also are useful in lowering the cholesterol. There are side effects. It's arguable how high the side effects are. The literature would say about 10% of the population are going to have significant side effects with statins. And we also know that there's a lot of problems with compliance, that people don't take their meds. So it's very nice that you're prescribing it, but they're not taking it. These are patients who won't take it because they have a philosophical, whatever it is, problem, or they would rather use something more natural. And so this is what we came out with from the world of nature. We absolutely do. It's just we have a lot of data on that which we didn't present, and that's actually going to be presented at the major conference that we present along with the paper. But we looked at whether they had a lot of other things, including hypothyroidism, their diet. We certainly looked at their physical activity. Some of them were high, a lot of them were low. This was done not in conjunction with the diet. They were already on. I mean, what I do at the center is I teach people how to eat. We'd already done that. That wasn't working because even if they did well, there is a proportion of the population who simply have a genetically high LDL cholesterol. You're going to have to get it down with something else, and it isn't just going to be food. Those were the patients that I've seen. And it's actually not 150 people over 5 years is not a lot because we see 10,000 patients a year. So this is a small sample. So that's a very, 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 very good question. And the answer to the question is as follows. The supplement, just a big picture here, the supplement industry has no regulation really other than the FDA treats it as a food, and so therefore it regulates it like a food, so it would be concerned if there are toxins. As to the regulation of red yeast rice, there used to be a standardized extract of red yeast rice that was standardized to monoclonin K. Red yeast rice has properties, some of which are cholesterol-lowering, statin-like. What you need to understand about an herb is that an herb isn't just going to work in one way. It's going to have 50 different things, and one of them is a monoclonin that happens to lower cholesterol. Unfortunately, the FDA decided that was too close to a statin because we were standardizing it to a statin, and so you can't do that anymore. So we have a reduced rice that we use, which is tested by the manufacturer. It is only sold to physicians. I don't actually sell any of this. It's just I prescribe it from a pharmacy next door. But honestly, in the supplement industry, you just have to know the manufacturer, who I know because I work with, and so I know the quality and I know that it's pharmaceutical grade. I would not, therefore, suddenly go outside, go to Costco and buy something. Well, actually, Costco's not bad. I wouldn't go to the vitamin store, try and do this and hope for the best, because I don't know where it came from. As I know where this came from, I can speak to its quality. I cannot say that about anything else. It's a big mess.
And just two questions. Does it matter what you ingest the supplement with? You were specific about it with almond milk and soy and 1%. And then your numbers in regards to responsiveness, how does that compare to what numbers you typically see in statin? The reduction in your numbers.
I'll answer the second one first. My very small preliminary study, which is not a massive statin study of 5,000 people, would seem to suggest that my supplement does a better job and reduces it more than a statin. However, that is a small study, and I'm not going to get into it with Pfizer. The other thing is, I'm not, the other thing is that in terms of why we used this, very, very briefly, one of the problems that people do when they use natural products is they use the wrong dose. They're using very, very small doses. This is the equivalent of 10 to 12 tablets. That's why people can't do this. This is why when you go to the vitamin store, you take one tablet. You're never going to get there. These are high doses used in a supervised fashion by a physician in a clinical setting. And when that happens, the only way to get 5 grams of this stuff into your body is as a powder. You can't take it in tablets. So therefore, we have to make it palatable, and hence we do it as a powder, make it into a milkshake. It tastes of dark chocolate. And so we just like almond milk or low-fat milk or rice milk, because they're probably not going to have a massive effect on the cholesterol. That's literally the reason. It was nothing special. We good? Okay.
So Dr. Greer could not be here today to present, so we are going to go right to Tina, if you're ready. We have Dr. Kramer from the surgery department, and she will be presenting her work. Thank you.
Excellent. Good morning, everyone. It's a pleasure to be here. I'd like to begin by thanking the committee for selecting my project for presentation. I'll be speaking about time in target blood glucose range and its association with survival in a cohort of trauma ICU patients. How do I go to the next one? Forward. Excellent. So just before I talk about my project, I'd like to speak briefly about the context in which this project takes place. So there's sort of 3 big domains of glycemic control that we look at in ICU patients. There's hyperglycemia, hypoglycemia, and glucose variability. The first big studies that looked at dysglycemia in ICU patients looked at hyperglycemia. It was noted that even patients who were not diabetic when they became critically ill had more episodes of hyperglycemia. So the first big study was published by a group in Leuven, Belgium in 2001 that looked at 1,500 surgical ICU patients and randomized them to either intensive glucose therapy with a goal of 80 to 110 milligrams per deciliter, or more conventional therapy with a goal of 180 to 200 milligrams per deciliter. And they were able to conclude that the intensive therapy group actually did better. They had a lower mortality. The same group from Leuven then repeated this study looking at medical ICU patients, published in 2006. However, that study did not show a mortality benefit. So because of this sort of disparate data, that was one of the things that prompted the NICE Sugar trial, published in 2009, very large study, 6,000 patients from 42 centers around the world, with a similar randomization to intensive therapy and conventional therapy. And they actually showed that mortality was higher in the intensive group. Now, when you look back at all of these studies that randomized patients in this way, all of the patients in the intensive therapy group had more episodes of hypoglycemia. And it turns out that seems to be what's associated with the increased mortality in those patients. In fact, the Leuven investigators went back and pooled the data from their 2 studies and were able to conclude that even one episode of severe hypoglycemia, so 40 milligrams per deciliter or less, was associated with over 3-fold increased risk of mortality. So clearly, hyper and hypoglycemia are not very good for you. That brings us to the glucose variability. Again, the pooled data from Leuven, they were able to calculate that if you look at the maximum and minimum blood glucose levels, the difference between the two, if you increase that difference by 18 milligrams per deciliter, that increases your risk of death by 5%, which is significant. Now, all of these studies that I mentioned look at both diabetic and non-diabetic populations. And we know when we look back, it's really the non-diabetic populations that are benefiting most from intensive therapy. It's not exactly clear why that is, but diabetics just don't behave the same way. So that brings me to the time in target blood glucose range. This is a relatively new variable in the literature, and it's nice because it kind of incorporates all three of these other variables, the hyper and hypoglycemia and the glucose variability. And it's basically exactly what it sounds like. It's the amount of time that a patient spent within the target blood glucose range. So we hypothesized that an increased time in range would be associated with improved outcomes in our cohort of trauma ICU patients. So in our ICU here at Stamford Hospital, we keep a comprehensive registry that is prospectively collected data on every patient admitted to the ICU. And it's from this registry that we've abstracted the data for the study and then retrospectively analyzed it. So the patients were admitted between January 2007 and September 2014. They all had a length of stay of at least 24 hours. And you can see here the target blood glucose range during that time. We have a nurse-driven protocol to help maintain patients within the target range, and this is the target during that time. There were a total of 526 trauma admissions to the ICU, 41 of which were diabetic, and our two time and range groups are here. So time and range high were patients who spent 80% or more of their time within the target range, and TIR low are those who spent less than 80% of their time within the target range. Okay, so this table looks at the diabetic and non-diabetic populations. So you can, do I have a pointer on this? Aha. So you can see there's only 41 patients in the diabetic group. They tended to be older and had a higher mean Apache score here. They also had more dysglycemia, so all of the variables that I mentioned before, as well as a higher mortality. This graph here shows that, again, the diabetic patients were less likely to spend time within the target range, right? That's over here, and then the non-diabetic populations are more likely to spend time within the range. So because we had very few diabetic patients, we know these two groups behave differently. We have excluded the diabetic patients from further analysis from here on out. So this table shows the time and range high and low groups of the non-diabetic cohort. And you can see here, again, so this is the time and range low. They did seem to be, they're older, sicker, and spend more time in the ICU than the TIR high group. They also had more episodes of dysglycemia, which is expected given the definitions of each of these two groups. But I really want to draw your attention to this line here, which is the overall mortality. And that's diagrammed here in this table. And you can see that the time and range high group had a lower mortality than the TIR low group, and that was statistically significant. So when we calculated the odds ratio, there was clearly a decreased risk of mortality in the TIR high group on univariate analysis. You can see that's statistically significant here. However, when we performed multivariate regression analysis to control for Apache score and ICU length of stay, this was no longer a statistically significant variable. So because we're talking about trauma patients, I just wanted to touch briefly on the different subgroups of trauma patients within this database. It's a little bit confusing, so I'll just take an example. So the first line here, the non-op head, are patients who had some sort of head trauma, may or may not have had body trauma, and did not have surgery. So you can see how these are there's a lot of heterogeneity in these groups. So though we did look to see if there was any statistically significant data, when we looked at subgroup analysis, there wasn't any, so I haven't included that here, but I think it's worth mentioning. So in terms of conclusions, time and range does seem to be associated with a decreased mortality in this cohort of non-diabetic trauma ICU patients, at least on univariate analysis. I just mentioned our subgroup analysis is hampered by small numbers and too much heterogeneity to be clinically relevant. We need to look to further elucidate. We need bigger studies to look at the association of time and range and survival. And in terms of the next step, I hope to be able to take this data from our ICU database and merge it with our trauma database, which has also captured these patients. And that'll give us some more information about the patterns of injury and that sort of thing, the complications, et cetera, which are certainly relevant when you're talking about glucose control in these patients. Thank you very much for your attention. I'll be happy to take any questions. questions? You already came by my poster, that's why.
No questions? All right, thank you so much.
So up next, we have Dr. Gaidos, who's also from the Department of Surgery, and he is going to be presenting some of his work on hepatic resection, if you're ready, and moving forward fast. So, all right on time. It's a clicker. Sure. If you need it, move forward and back.
Good morning. Thank you for the opportunity to present our work today. The title of our presentation is Liver Resection for HCC, which is hepatocellular carcinoma at academic medical centers associated with improved survival. Let's talk a little bit about the scope of the problem. So HCC is increasing in frequency in the United States. In 1975, there was about 1.6 cases per 100,000 of the population. In 2005, this has increased to about 5, so more than 3 times in a matter of about 30 years. In general, HCC is also associated with poor survival. The survival rate is, for all comers at 5 years, is somewhere between 11 to 30%. Obviously, the reasons for that is multifactorial. However, if you look at well-selected surgical series, the survival could be as high as 50 to 70%. There have been several studies looking at perioperative mortality in the setting of liver resections for HCC, and various factors have been associated with it. Obviously, clinical factors play a role. The more advanced the disease, the more extensive the resection, the more chance for complications and possible death. So stage, size, AFP, so on and so forth, have been all related to increased mortality. People have studied hospital volume, surgeon volume, and teaching status, and studies, larger database studies have also proven or showed that surgical volume, hospital volume, and teaching centers have variable outcomes amongst them compared to non-teaching or low-volume centers. However, the effect of facility type or surgical volume on long-term survival in patients with surgically resected HCC has never been studied to our knowledge. Our goal was to try to shed some light on this poorly studied topic. We used the National Cancer Database, which is a, you have to be a participant to enter data, but it covers about 70% of newly diagnosed cancer cases in the United States. There is about 100 different diagnoses, and there is hundreds of thousands of patients in the database. The National Cancer Database was started in 1998. We took a sample from 1998 to 2011. The reason why we didn't go further in years because we obviously wanted follow-up data. Inclusion criteria for our study was a diagnosis of HCC as well as a formal surgical resection, at least in the form of a wedge or segmental resection and above, and all cases with other local therapies have been excluded. Cases that did not have a final diagnosis of HCC after surgical resection have also been excluded. Patients who were treated with liver transplant were not part of the study. Let's spend a minute in describing the facility types that are categorized. They have 3. Actually, at the time of this study, had 3. Now, these days, have 4 different type of categories in the National Cancer Database. There are community cancer programs that diagnose somewhere between 100 to 500 new cancer cases. Those could be any kind of cancers. Each year, they may have cancer-related research, and they may train residents. There are comprehensive community cancer programs that have greater than 500 newly diagnosed cancer cases, any kind of cancer. Again, they may have cancer-related research and may train residents. And academic cancer programs, 500 or more newly diagnosed cancer cases, and they have cancer-related research and at least 4 different residency programs or training programs. We also further categorize programs into liver transplant programs and non-liver transplant programs. This is not to cause any confusion. Liver transplant status of a medical center obviously portrays a higher level of expertise in liver surgery. Liver transplant patients have been excluded from this study. In terms of volume status, nobody has ever defined what exactly is high volume for surgically resected HCC based on pancreatic cancer data, where most of the time we use a cutoff of 10 per year. We decided to use high volume status for 10 hepatectomies for high volume or less than 10 for low volume centers. These are the statistical methods that were used to analyze the data by a highly trained statistician. Of note, somewhat related to your earlier comment, we spent probably close to 2 months to clean this data before we started the analysis because there's so many discrepancies. This is what the data looked like from the beginning. On the top, you can see that we had a total of 158,000 cases with a diagnosis of HCC, with a diagnosis of liver malignancies. When you focused on HCC, primary liver malignancy is 137,000 patients. We excluded the ones without surgery, or we excluded the ones that did not have what we defined as a surgical resection, or less than that. That left us with over 12,000 patients. On the grand scheme of things, this is only about 8% of cases. So you can see that there's a large number of patients nationally between 1998 and 2011 that did not even see a surgeon or were turned down for surgery, unfortunately. The type of cancer programs, community cancer program, have operated on 483 patients. Comprehensive cancer programs operated nearly 4,000 patients. Academic cancer programs operated over 8,000 patients. The breakdown of surgery was pretty comparable. Segmental resection was over half of the patients in each category. Lobectomies made up about a third of patients in each of the teaching status. Based on teaching status, there was very few patients who had extended lobectomies, which is removal of 4 or more liver segments by definition. What happens when you compare patients in a univariate unadjusted model? You find that patients who go to academic cancer programs are younger. They're more likely to have private insurance. They have higher income, so more mobile and have time, money, and knowledge to travel. They have a higher level of education. They live in more likely to live in the metropolitan areas. They are treated in the more recent time periods. They have earlier T-stage tumor, lower T-stage tumor, or lower stage in general, because they get diagnosed and treated earlier, and they're more likely to have negative surgical margins. We didn't find any difference between other variables, like gender, Charlson-Deyo score, which we used as a surrogate for comorbidities, chemoradiation, INR, AFP, cirrhosis, number of positive lymph nodes. What was or perioperative mortality? So perioperative mortality is something that has been studied before, not really on this scale, more so a unit of one institution or maybe a few institutions putting data together. For academic cancer programs, the 30-day mortality in this database is 6%. For comprehensive and community cancer programs, it's about 9%. Some people would argue that 30-day mortality is not sufficient for major operations. So we looked at 90-day mortality, which is 11% for academic cancer centers, 15% for community and cancer programs and comprehensive cancer centers. These are all unadjusted. Volume is not being accounted for. In the interest of time, I'm going to skip to the multivariable model and Cox proportion hazards model, looking at what variables have been correlated positively with outcome, which was overall survival. Of note, the National Cancer Database does not have any information on local or distant recurrences. The only hardcore endpoint is survival. So variables that have been correlated with survival in adjusted analysis have been stage, age, tumor grade, size, income, liver transplant status of the center or not, sex, race, AFP level, Charlson-Deyo score, year of diagnosis, insurance status, facility type, cirrhosis type of surgical procedure, and surgical volume. Variables that have not been related to outcome is chemotherapy, radiation, education, and living location. These are adjusted survival curves per facility type. ACP is academic cancer programs. On the top in blue, about 8,000 patients. Comprehensive cancer programs in the middle, 3,800 patients, and community cancer programs, 483 patients on the bottom. So this curve would suggest that cancer or teaching status is important in finding long-term outcome. All these variables were highly statistically significant. And as you can see, we have survival up to 15 years, which doesn't happen very often in the setting of surgically resected HCC. To study this topic further, we started looking at variables like transplant status and volume and how that affected outcome. And data are not shown here, but we found that after additional adjustment, transplant status was an important variable, more important than teaching status. But overall, the most important variable was volume. So we split these cancer centers into high-volume academic cancer centers, which had 7,500 patients, and we found that the 10-year survival is 32%. The next category was high-volume comprehensive cancer programs. We found that their 10-year survival is 29%. Low-volume cancer, comprehensive cancer programs and low-volume academic cancer programs have survival around 25%, while the lowest survival was in community cancer programs with 22%. There's only one community cancer program in the United States that entered data that had more than 10 cases performed each year for any kind of liver resection, not specific to HCC. So if you look at adjusted survival curves, those were the 10-year numbers that I showed you, but you can see highly statistically significant differences between high volume and low volume status between the same teaching category. So high volume academic cancer programs on the top, low volume academic cancer program almost on the bottom, not much better than community cancer programs. So again, these curves just to prove that teaching status is important, but volume is more important than teaching status. So just because somebody has an academic cancer program by designation in the National Cancer Database, that doesn't mean that their 10-year survival for surgically resected HCC is going to be better than a comprehensive cancer program. So what did we conclude? Well, we found that liver resection for HCC at high-volume cancer programs improved 30-day, 90-day mortality, as well, which data are not shown here, as well as long-term survival up to 15 years. We speculate, we don't have obviously clear evidence, but we speculate that this survival advantage is multifactorial. There are patient-related factors, although they should be adjusted away with adjusted analysis. There are tumor-related factors. They're also adjusted away with adjusted analysis. So we believe that this has something to do with the institutional experience in high-volume centers. For instance, if you look at margin status between academic cancer programs, comprehensive cancer programs, and community cancer programs, i.e. having a positive or a negative surgical margin after resection of HCC, you can see statistically significant differences with academic cancer program 10%, comprehensive cancer program 12%, and community cancer programs 13%. So obviously there's a level of difference in expertise. Obviously this is not something that we can prove, but I think it's a reliable or a reasonable thing to think. The limitations of our study recurrence rates are unknown. Other variables that probably affect survival are multidisciplinary clinics, which I think is very important, not just seeing patients individually, but together and making decisions with your interventional radiologist. Probably patients in high volume centers with transplant status, with or without transplant status, have more advanced training, both for surgeons, non-surgeons, interventional radiologists. Probably there's more available advanced diagnostic technology, and access to healthcare has also is something to think about. Just the final conclusion is that although patients operated on at academic cancer programs seem to have initially statistically significantly improved overall survival compared to community and comprehensive cancer center, once we adjusted for cancer program volume, facility type was no longer associated with overall survival. So volume status is more important than teaching status. Patients undergoing liver resection at high volume cancer programs had statistically significantly improved 10-year survival than other facilities. Based on that, I think it's reasonable to think that some sort of a regionalization of treatment for HCC may improve long-term survival. Let me put this into perspective for you. I think this is an important piece of information. So Saranifab, which is the most commonly or one of the most commonly used medical treatment for advanced HCC, got FDA approval in 2009 based on a prospective randomized study with about 600 patients from all over the world based on a 3 months overall survival advantage. 3 months overall survival advantage. What we found in our study, that if you think about regionalizing cancer care for HCC, your 5 or 10-year survival could have a vast difference between low volume centers and high volume centers, somewhere between 22% versus 32%. That's more than what you can achieve with additional medical therapy. Thank you for your attention. Any questions? Yes, sir.
Yeah, so these results speak to the clinical skill of the surgeon and the associated team of high-volume centers. Does the database include any information regarding morbidities, transfusion requirements, infections, length of stay?
Unfortunately, it doesn't. So the variables that are available are, socioeconomic. You can, sort of study access to care. You can look at clinical and high-level pathologic staging, but you can look at mortality, but you cannot look at other morbidities that traditionally are being studied. You can look at those in the American College of Surgeons National Surgical Quality Improvement Project. The problem with that is that the follow-up is only 30 days. So you cannot study long-term survival. There's a VA database that is really basically the ACS started out of, and therefore follow-up is only 1 year. So unfortunately, there's no currently available large volume data set with this kind of degree of accuracy in terms of perioperative variable or tumor variables and surgical variables that I know of where this could be better studied. Yes.
Is there any evidence that patients treated at the high volume centers are identified earlier and treated more rapidly because they have more of a multi-disciplinary?
Yeah, if you remember, I showed you some of the slides earlier that in univariate analysis, some of the variables. So this is not by volume, this is by teaching status. So I'm not really answering your question correctly. But what we found is that younger patients living in metropolitan areas with higher income and private insurance are more likely to migrate towards academic cancer centers. So there's definitely an element of that. But when you do the adjustment in the survival curve, all these differences should be adjusted away. So we can't really say that that is the main reason why that happened. Hmm? Yes?
Very interesting. For the community cancer programs, was it programs or did I hear you right? It was programs.
Programs,
So how
yes.
many were in each?
I would have to go, but I can't tell you exactly the number. But 483 patients, most of the community cancer programs have had low volume, 1 to 2 patients a year. So there was a significant number of you had a number 1 related to community cancer program. That was for high volume. Out of the 483 patients, there was only 1 patient who was operated on at a high volume community cancer program. All the rest of the patients are operated on at a low volume community cancer program, and most of the community cancer program have entered much less than 10 patients. So there's a large number of community cancer programs in the study. Thank you.
All right, up next, we have Dr. Krinsley, who's going to be presenting on behalf of Krista, who's stuck up in the ICU. So thank you for filling in, and enjoyed hearing your presentation.
Thank you. We appreciate the opportunity to make this presentation and for being chosen for an oral presentation. And what do I do to turn it on? Okay.
Magic.
Okay, so this is another glucose story, and Dr. Kramer very eloquently provided an excellent background for this talk. So glucose control in the critically ill became a very hot topic in 2001 following the publication of that landmark study from Leuven, Belgium. And in fact, the day after that study was published in the New England Journal of Medicine, started our own trail of glucose control. And we've been heavily involved since 2003 in research and projects relating to glucose control. The three domains of glucose control that are classically described include hyperglycemia, which is the target of insulin, hypoglycemia, which is the unifying complication of all of the interventional trials and has been shown to be independently associated with increased risk of death. Even mild hypoglycemia, even a single episode of glucose less than 70 in studies that we've participated in has been demonstrated to be independently associated with increased risk of death. And the third domain of glucose control that we look at is glucose variability. How much is the glucose bouncing around? We've also noted the fundamental differences in the relationship of these metrics to outcomes when you compare patients with diabetes and patients without diabetes. And so those are the sort of overlying themes that were behind this project. So we had had glucose control in range underway for quite a long time, and the goal of this project was to reduce the number of hypoglycemic events that we had in the ICU. It was already sort of low, but we wanted to see if we could make it lower. And this is a nurse-driven project. There's a group of nurses that Sally Gerard, our nurse educator, and Krista, one of the staff nurses, really led, and I was their mentor, and I just am happy to be able to present the data. So the goal of this project was to develop a nurse-driven initiative to decrease hypoglycemic events in critically ill patients while still maintaining glycemic control through the use of a root cause analysis form. So I've presented a lot of this background already. So this is a retrospective investigation of prospectively collected data that we got out of the comprehensive ICU database. And the idea was that the nurses designed a root cause analysis form that in real time they were tasked, sort of forced, to analyze every blood glucose level less than 60 when it happened at the bedside. So the form included what were the risk factors for hypoglycemia, and from the literature we identified renal failure, liver failure, diabetes, mechanical ventilation as potential risk factors for hypoglycemia. And then they also were asked to identify the circumstances around the hypoglycemic event. What was the glucose level 6 hours before, 3 hours before, and so forth? And was there any change in the insulin therapy or nutritional therapy that preceded the hypoglycemic event? So they were asked to fill this stuff out in real time. Not only that, it went into their incentive bonus program 2 straight years. So achieving 80% compliance with this filling out these forms resulted in achieving their bonus. So they had a financial incentive to do it. So they started paying attention to glucose really intensely. And in fact, as a side effect, I mean, I just learned this today, the nurses were like so about doing this that they didn't want to fill in the forms, which was one of the reasons why they were paying such close attention to the glucose levels. That's what Araceli told me today. So the idea, so this is a large a series of patients. Before we started, we had 2 years and 3 months of pre-data. That was before implementation of the protocol. Let's see, how is the, nope, I'm sorry. Where's the pointer here? Which one? Okay, so 2,200 patients in the 27 months before we started. We call that the pre-phase. Then we have the implementation phase. That's 2,600 patients admitted over 27 months. And on 229, which is, what's that called? Leap year day. On leap year day, we said, okay, you guys have done such a great job, because we'll be showing you the data, that we don't have to do it anymore. So we stopped asking the nurses to fill in the forms. And then we looked at the first 500 patients admitted after they no longer had to fill in the forms. We called that the continuation phase to assess whether this had legs, whether it could be sustained over time. Now, during this whole period of time, the glucose target was 90 to 120. The monitoring frequency was at least every 3 hours on every patient admitted to the ICU. And the nurses had a nurse-driven insulin protocol, which was really considered a detailed guideline, but they were driving the insulin train down the road. Everybody had the same target, and the nurses were deciding insulin dosing at the time at the bedside. This was IRB approved. So this table, sorry for its complexity, describes the baseline characteristics of the patients. I'll summarize it. When you compare the pre-phase to the implementation phase, the gender was similar, age was similar, severity of illness was similar, percentage of patients with mechanical ventilation was similar, diabetes status was similar. There was a slight increase in the number of medical patients during the implementation phase, and comorbidities were similar. This is our headline figures. This figure shows what happened to hypoglycemia rates among patients with diabetes, and this one shows what happened to hypoglycemia rates in patients without diabetes. There are 3 lines. The first line is any blood glucose less than 70. The second line is any blood glucose less than 60. And the third is any blood glucose less than 40. So that's severe hypoglycemia, less than 40. What you can see is there's a dramatic reduction in hypoglycemic events when you compare the pre-phase to the implementation phase for patients with diabetes and without diabetes. These changes are very statistically significant. And notably, after we stopped having them fill in the forms after leap year day, there was a further reduction in hypoglycemia for patients with and without diabetes, suggesting that the lessons that were learned during this whole process got embedded into the culture of bedside patient care. It should be noted that when we were doing all of this every month, we'd have a meeting of the glucose group to discuss how the stats were the previous month, what the hypo rates were, what the mistakes were in terms of management, and we reported all of these findings to the staff nurses. Continual barrage of colorful graphs out of my office color computer. So there's a continual data feedback is the way that you affect change and maintain change. So reduction in hypo that was sustained after we stopped asking the nurses to fill in the forms. But that's not all. So we talked about hypoglycemia. As a surprise additional benefit of this intervention, we found that hyperglycemia, or mean glucose levels, in fact went down among patients with diabetes. Well, you could, without diabetes. You could say, well, we're not having hypo because the nurses just let everything go up. Well, that isn't what happened. This is the patients without diabetes. The mean blood glucose level in the pre was 121, which is very low for an ICU cohort. And it went down to 117 and was sustained at 118. So while hypo was being better controlled, the mean went down as well. And among patients with diabetes, the mean was stable as hypo went down significantly. And the third domain of glycemic control, glucose variability, which has been independently demonstrated to be associated with mortality, high variability. You don't want the glucoses to be bouncing around. That also went down. Coefficient of variation is the metric for glucose variability. Very significant reduction among patients without diabetes and patients with diabetes. So while the nurses were paying attention to hypoglycemia, all of the domains of glucose control improved at the same time. And the intervention and the results of the intervention were sustained after they stopped having to fill in the forms. So in conclusion, this is a nice example of a nurse-driven, data-driven bedside protocol that asked the nurses to use their cognitive facilities to make an analysis of what was going on at the bedside, make decisions at the bedside, led to sustained improvement in 3 domains of glucose control that was sustained after the official project was terminated. We're very proud of the nurses' work, and I'm happy to present. Thank you very much. So, any questions?
Was there any change in mortality? Did you look at that? Was there any, long, maybe 30-day readmissions or mortality that you were able to look at the same time?
We don't have readmission rates. Mortality was stable, but having said that, we have published back in 2004 our initial intervention showing glucose before and after study showed a marked reduction in mortality with glucose control. And more recently, in March of this year, in endocrine practice, we published the first intervention of 2 blood glucose targets. We've moved on from a single target to 2 targets and have demonstrated that among patients with diabetes, using a looser target for patients with diabetes and an A1C greater than 7% led to a reduction in severity-adjusted mortality. So the answer is that, yes, we have continued along that path of improving patient outcomes. Thank you. Yes, Dr. Dwyer.
I'm just curious, during your root cause analysis, what did you find out were the most common changes of hypoglycemia?
Great question. So, in terms, I think the largest percentage of episodes were associated with failure to increase monitoring frequency. So I'll just make up an example. If you're not on intravenous insulin, the monitoring frequency would be Q3, and if you're on IV insulin, the monitoring frequency would be Q1 hour. So a typical event would be a blood glucose went from, let's say, 250, the patient got insulin, and not on IV. It was just a subcutaneous dose because 180 twice in a row triggered IV. So maybe the patient just got a subcutaneous dose. The next blood glucose level was 120, and that should have, per the protocol, initiated a blood glucose check in 1 hour. Instead, it was checked in 3 hours, and it was 59. So the nurses, had to learn to, one of the things to notice was a drop had to lead to a change in monitoring frequency. And I think that's one of the lessons that was learned over time that led to a reduction in hypoglycemia. So I think that was the single largest group of findings related to hypoglycemia, failure to monitor frequency. So it was insulin therapy, and then failure to increase the monitoring frequency.
It'd be interesting when we finally get real-time glucose monitoring. I know you've been working on that for a long time. To let the although it's so low now right now, you can see the variation.
With continuous or near continuous monitoring, a low level will become should be almost a zero level. Any other questions? Yes.
One more. So I'm sure this change didn't happen overnight. Can you talk about some of the challenges or maybe resistance that the staff went through, and maybe some advice to other units who might say we need to implement a change, some feedback as to how to do that, how to overcome the initial resistance?
Right. Well, the resistance was completely based on the fact that here we are asking people to do a fairly complex piece of cognitive work in the middle of a busy day or busy night. So, ICU nurses are very busy, 2 sick patients usually, and if something happens, then here you are faced with this piece of paper that you have to, do an analysis. It might take, 10 minutes out of your day or night. So that was the resistance. The overcoming that resistance was the way you overcome any resistance is continual data feedback. You just have to show people, here's what we're learning, and here's how you're doing, and gee, you're doing better. In this case, there was a financial incentive as well, which helped to break down the resistance. And, PMPs, every department has PMPs. The nurses chose to make this their PMP 2 years in a row. So, so they chose this as their thing to work on. So, but the data feedback piece is really, really important. You have to, we're in the ICU, we have a very robust data system, and we use it to support our clinical initiatives. And the nurses are used to this. I think we have glucose in our blood at a good level, 90 to 120. But, it's sort of part of the culture. And new nurses who come in, just learn that culture. Okay, thank you.
Okay, last up we have Dr. Drugi. Is he here? No? Oh, okay. Okay, we had one cancellation or a little bit ahead, so if you can speed up. I don't really think people want me to sing and dance up here, so. That's not on the program today. All right, well, we'll give it a few minutes, and I'm sure he will be here shortly. And can pull up his presentation. Pointer for you, backward, forward, and then the laser. Okay?
Thank you.
Fair enough.
Good afternoon, everybody. I'm going to talk about our experience in melanocytic lesion tracking, where we're using time-lapse total body photography and dermatoscopy, and this will be hopefully a brief talk. We all know that melanoma is increasing at about 1.4% a year. Although there is a stable mortality rate, it still claims 10,000 lives a year as we have an expanding U.S. population. And the severity is worse in the older men. You can see here men over 50, and the new adjusted line have quite an increase in risk. Women, too, it becomes the most common cancer death in a woman between 25 and 30, and melanoma has a very long lead time, perhaps 15 to 20 years before it kills most people. So there's a huge lag time for us to be able to recognize the melanoma in situ. And this is really where we're trying to push melanoma into the in situ area where they have actually zero melanoma depth, and the melanoma diameters are quite small in this range, and that makes them very difficult to observe by traditional methods. So we are actually going to present information about how we use E on this slide, not ABCD, but E for evolving, where we see subtle changes in the lesions in time-lapse imagery. We are looking to compare this to a study with traditional methods where people have visual skin examination, which is performed by either a dermatologist or a primary care physician. Many studies have shown a 50% false negative rate for the presence of melanoma when performed by a primary care physician, or 40% false negative rate when performed by a dermatologist. On that basis, the United States Preventive Health Task Force disagrees with the recommendation of melanoma or skin cancer screening, relying therefore on the patients to self-identify. The state-of-the-art methods we're going to present today is to automate total body photography and to use digital dermoscopy to identify subtle time-lapse changes. The device we're looking at is an array of cameras, which is covered by insurance, about 70% insurance, including the one that covers our hospital group, United, and Medicare, Aetna, and Connecticut all cover this for people who have a personal or family history of melanoma or have more than 4 atypical moles. Typically, people who have 50 atypical moles have 5 atypical moles on their arm, or 5 moles of any size, 2 millimeters or above on an arm, predicts having 50 moles in the body, and 50 or more melanomas is predictive. Now, this is a fairly low-cost service, which runs about $90 to $120 for insurance. And without insurance is a mere $150. And we get a very high compliance rate in the population. We have increased patient and physician confidence documented. We put patients in 3 positions with no radiation to expose the areas of their bodies. Clothing is optional. People can wear thongs or bikinis. That's really not much of an obstacle. Hair should be drawn out of the way. And tattoos actually are not that much of a problem for us. Here is the view of the total body photography Mosaic, excluding the top-down camera views, which we found very important, especially in men who are balding. We currently use 25 cameras. We create this time-lapse comparison, which is essentially an animation of the body as it transforms over time. And we track XY coordinates and annotate the lesions. We're working through with artificial intelligence and deep learning to try to automate the entire process on the basis of our 4.4 million image data set that goes back 17 years. Here's a typical lesion. This, believe it or not, is a millimeter mark right here. I think you're able to appreciate how tiny this lesion is, and it erupts into this invasive lesion as early as 15 months between scans. There's nothing on the left, and on the right you see the new spot, and then up close you see the dermoscopy with a 2 millimeter size lesion, and this is already on its way to invasive melanoma, carrying about a 0.45 millimeter or 5% rate of metastasis for this type of lesion. So when we look at the lesions we're addressing this study, this is an 18-month study when we're just taking every single melanoma that comes through the office, and we see this frequency of these melanomas. Group 1 are lesions less than 3 millimeters in diameter, and this is the frequency of their biopsy. And then so of all lesions, we take many more biopsies in the green category, And then as far as the right side, the malignant side, we're able to see that we have an even distribution of about a third of the melanomas end up less than 3 millimeters. In group 1, about a third of the melanomas end up with a 3 to 6 millimeter classification. And then lastly, in the group 3, we have a third of the melanomas. Now I'm going to refer you to a study that was done in preparation for a system called Melifine, which is the only FDA classifier. That's the Abbasi study on the right compared to the Drugi study. This is our study on the left. What I want you to focus your attention to is the number of MIS melanomas that are tiny. So we have 35 MIS melanomas, and the worst melanomas would be the larger invasive ones. So we have a ratio of 3.5 to 1 here versus in the Abbasi study, which is just a traditional dermatology expert group, finding the MIS ratio of 1 to 2. So they are, believe it or not, taking 1,600 biopsies to achieve this number of 22 MIS lesions, whereas we take only 268 biopsies, an enormous reduction. If you take, for instance, a number of $1,000 between the pathology and surgery, that's $268,000 spent versus $1.65 million spent on the Abbasi study, showing a dramatic reduction in cost to get to these minimally invasive lesions. So the ratio of 3.5 to 1 of the large dangerous disease versus the small harmless disease is completely in the favor, inverted, and that is the power of the system to reduce the cost of care delivery. So you see that again, how the ratios run and how we're able to dramatically reduce the cost. Our greater, the ratio of biopsies is 3.3 biopsies per melanoma versus 12 to 1. So there's basically that all reduces cost not only in the downstream survival data, because large melanomas that are more invasive are more dangerous, but also in the actual screening costs. They've been dramatically reduced by about 3/4. So we see that again with these ratios, the number needed to excise. In the Abbasi study, or in the black versus our study, you can see in the smallest group, the cost per discovery is higher, and we think part of that is because there's a tremendous discordance among pathologists at this lower end. They are not comfortable many times looking at these tiny, tiny melanomas. Typically, melanomas less than 2 millimeters are not even called for what they are. There's always some kind of confusion in that level. And here we see the data again, where we have a great proportion of the spots we take for biopsy for melanoma to be melanoma, 30% on the left versus 8% in the Abbasi study on the right, and a comparable MIS to invasive ratio. And again, the depth of the lesions we have a very high percentage of the lesions biopsy being MIS or melanoma versus the Abbasi study. So this is just a demonstration of how sensitive and specific we can drive the screening process to be, thus averting the cost of screening and dramatically reducing the downstream adverse consequence. So in conclusion, we've really enriched the population of small, non-invasive melanoma at a very low cost by using mapping and tracking, which is covered by 70% of insurers in our market. And so a third of the melanomas are less than 3 millimeters, a third 3 to 6 millimeters, and a third in the classical, remember, D in diameter, ABCD is 6 millimeters or larger. Only a third of our lesions are in that large group. And so I'm opening this up to question because what we're able to do here is to reduce the MIS invasive ratio to 1.7 compared to the national average of 0.96. So that means we're delivering safer lesions which are less likely to metastasize. MIS is unlikely to metastasize. So I'm opening this up to the group, and I'm done with my talk. Yes?
So, as you know, I'm a proponent of this, and I love that you've been doing this for quite a while now. And insurances have picked it up. So, quizzically, why is it that this isn't just standard of care now?
So what you're talking about is really what we call scalers. How do we scale a good project into a large project? We've been addressing that. One is networking. It's hard to take a device like this and network it. So what we're doing currently is changing to a cellular cell phone, like a cell phone booth, essentially. So we go right to the cloud with every device. Because when we put this in, for instance, to the Stamford system, we had to go through the HIPAA privacy concerns of the specific hospital setting, and the way the IT department works in every single institution is very difficult. So that's a confounding element for deployment or scaling. The other deployment limitation is automation. And so we're working very tightly with artificial intelligence, deep learning groups to create a wholly automated process. This currently works on the basis of technicians looking at animation. So that's a scalar factor that we're looking at. And also, just the cost of deployment. So with current technology, we're looking at using actual thin panel display deployment into an extremely lightweight product, which makes it easy for us to get out into the field. Yes, no. Thanks.
Had conversations about this over many years. You certainly deal with most primal principles in medical care. The more proximate that you can pick up the disease process, the better the results, the more ideal the state that you will achieve. Have we reached that level of technology where it isn't even necessary for human interpretation of these lesions?
Yeah, there was a
radiology.
Nature article that came out of Stanford, which was populated by Sebastian Thrun, who runs the Google X car project, and also Andre Esteban and Susan Sweater in the dermatology department at Stanford. And they showed that by feeding 129,000 lesions to a system called Inception, using something called TensorFlow, which really is matrix algebra, that they're able to reproduce what dermatologists can do for classification. Now, they only had a few number of bins or classifications that they dealt with. They dealt with one classification system which separated into benign, malignant, and inflammatory, pretty low level in terms of discrimination, but they were as accurate as dermatologists. And they further did a study with about 8 bins, which was as accurate again as dermatologists. And these dermatologists were drawn out of training programs from the Harvard, Yale, Columbia, Stanford programs. So yes, it is quite possible that what we're going to be seeing fairly soon is an automation of skin examination from head to toe with greater accuracy and sensitivity and specificity than we can currently achieve with our own clinical perceptions of visual skin examination. And I think that's a tip of the iceberg for other elements of physical examination, frankly. Yes?
I know also that you've been a very strong and outspoken advocate of prevention of this disease in so many ways. Of course, there are cases that arise de novo, but the risk factors that people subject themselves willingly.
Yeah. Well, I think that the real challenge here and what we're seeing is an extremely slowly evolving type of cancer. So the opportunity for early detection couldn't be greater. Unfortunately, there's not an awareness of the risk factors, even in the medical community, of who should be triaged to screening. Anyone with 5 or more moles on one arm, it's just a simple thing. And certainly anyone with 10 or more moles on an arm that are 2 millimeters or larger should be triaged to screening. And this becomes the most common cancer death in women between 25 and 30. And I'm certain that those lesions all start in teenage years. So the idea that we should be missing any of them is, in my mind, especially in the young age group, is a little bit crazy. As people get older, the modeling of the skin on a forearm is another way of looking at it. So I have a simple ambassador test where I do this is the initial part of the physical examination. You take someone's hand, you grasp their hand, you shake the hand, and you say, hello, how are you? And then you turn their hand over and look at their forearm. And then you make a decision. Are they under 45, 5 or more moles? They're in. If they're over 45 and they have that kind of Neanderthal, sun-damaged look, then they're in. It turns out that anyone with any non-melanoma skin cancer has about a 10-fold increased risk of getting a melanoma. So, we look at the young people with lots of moles and older people with sun damage or non-melanoma skin cancer, and those are the two populations that we should screen for early melanoma because it's a lot more cost effective. And so when we look at the cost effectiveness of it, we are estimating that in my clinic alone, where we take off about 60 melanomas a year, which is probably about 40% of melanomas that are removed in Stamford, we are saving about $750,000 a year in screening costs because we're dramatically damping down the pathology requirements. Number two, if we avoid end-stage treatment, that might go for $500,000 per case. So maybe 2, 3, or 4 people get spared that end-stage consequence, stage 4 disease, which costs about $500,000 maybe. So we're looking at $1 to $2 million of savings there. And then the real consequence is the quality-adjusted life years. The number of life years lost by a woman to melanoma is 21.4 years. And to a man, it's 19.6 years. So if we look at the global aggregate of quality lost to melanoma, it's about 200,000 qualities per the United States per year lost to melanoma. Those would be 200,000 people who would be in our midst, in our community right now. Now, I have a very special family history of melanoma. I've lost 4 close friends and family to non-melanoma skin cancer in 1 case and melanoma in 3 cases. And we have 9 melanomas in my second-degree family. So I'm on this. I have to be on this. I can't give up my post. I have to, be a watchful eye. But when we look at things like what we have in the military, we certainly have early warning defense systems where we can see the incoming, and we should be able to stop that incoming before it becomes a deadly consequence to our ships, to our sailors, to our anyone. So we in medicine should adopt the same kind of surveillance techniques. Yes, Sal?
Does this have any predictive value for lesions that were seen during one screening and then gone or washed away? Melanoma?
Yes, regression is seen. We have a couple of cases where we are seeing regression occur, and we do have 1.5% of melanomas occur without any known primary. And I believe those melanomas represent evanescent presence of a melanoma on the skin. It's curious that our very early melanomas almost all show regression. Some degree of inflammation is present in almost all of our early melanomas. Elgita, can you comment on that?
Yeah, it's very true. Even in some of these very small ones, you'll see we always comment pathologically whether there is evidence of regression or not. And for some reason, most of these, even though they're so early, do have evidence of regression. And that's also a clue for us to call it a melanoma, even though it's so small. We don't usually see that in small nevi. Every time you have your immune system attack the lesion, it's sort of a clue that it's probably something that should not be there. So, yeah.
Right. I wanted to put a shout out to Elgita for helping us out with almost all these cases. She was the pathologist, and we had many times 2 readers. Her former professor from Harvard was helpful. And my sister, Elizabeth, who's here in the audience, she teaches statistics epidemiology at New York Medical College, and she's in the audience as well as my parents, who've been very supportive through all this, and Carol Niebel, who's helped us out in innumerable ways to get this project to where it is. Thank you very much. Thank you, sir.
So if I could just have our oral presenters come up. I have a small gift for all of you, and then we're going to have the top 2, which we'll announce at the awards ceremony. So Dr. Drugi, Dr. Quinsley, is Dr. Kramer still here, or did she need to leave? And who am I missing? So did Tina have to go? Oh, and Dr. Guidos as well. Okay, well, we just have to, I gave him his already. So just a little certificate thanking you. Oops. And a gift card. Split it amongst the authors. We'll spend it all in one place, so let's just give him a thank you so much. All right. So up next we have lunch. We have a guest speaker during lunch, Greg Williams. I believe it's being set up right now. All right, perfect. So this is a very important month across the country as we are really trying to really increase the awareness of opioid dependencies. So our hospital especially dedicated Schwartz Grand Rounds to this topic this week. And also we had a lot of nursing involvement as well, with journal clubs being presented all over our nursing floors. So this just ties into that as well. So we can go over and you can grab some lunch and then we'll get started. We'll be back here at 1:15 for awards. Thank you.